An ostomy is where they make an exit for your intestine on the surface of your skin. There's a pouch that is peel and stick that we teach people how to put on to contain either stool or urine. There's several different types of ostomies. There's one that's a urostomy, which is one that is for urine. Ileostomy is your small intestine or your ileum, and a colostomy is your colon. I would say 75% of our ostomies here at UAB are temporary. It is fantastic. And a large majority of ours are ileostomies. A J pouch is Dr. Heslin and a lot of our GI surgeons here perform this, and it's a beautiful thing, okay? Used to, if they took out your large intestine, you would have a permanent ileostomy. Now they can form a pouch internally. So you would have a temporary ostomy to let everything heal that they've constructed inside, and then in 3 months they will take that down and you go like you would normally use the bathroom. I always tell my patients, I figure you might as well laugh about it as cry, because most of the time it's temporary. And I always just try to get them to own it up, name it, call it something, Rosebud or Henry or something. He's yours, and think of it as a different exit hole. That's really all it is. It does not have to be anything but a different way for you to go to the bathroom. And I said, in these days, the appliances are so flat. I said, nobody has to know you have an ostomy unless you choose to tell them. We want the patients to have the best quality of life they can, to be able to go to church and go to the beach. And yes, they can swim with a pouch on. They can sit in a hot tub with a pouch on. They can hike to Mount Everest with a pouch on. The ostomy shouldn't limit you from doing anything. In fact, there's triathletes that have ostomies. They do the 2-mile swim and the 26-mile bike ride. We talk to them about, what to eat, and really with a colostomy, there's no issues at all. You can eat what you want, you can drink what you want, you can take any medicines that you normally took. Ileostomies are a little bit more teaching involved because you don't have a large intestine anymore. So your large intestine is what absorbs the fluid, so you have to watch out for dehydration, especially in the summer. We talk about chewing your food because you have a smaller exit. We also have pre-op kits that we leave over there with printed information and all for the patients, and they will give that to them. And if they have questions, then they can call us. If they ask us to, then we come over to the clinic, the Kirkland Clinic, when they're seeing the patients, and we actually talk to them some pre-operatively. The first day I do a demonstration. Second day, I usually talk about where to get their supplies and prescription type things and how to treat skin irritations, and there's lots of different things that we talk about because I don't want to change the pouch every day. They're made to stay on for a week at a time, 5 to 7 days. And the third day, I usually go back in and they have to change their own pouch while I'm standing there. And I'll do verbal assistance or, if they need it. But most of the time, if you touch it and feel it and do it yourself, it sticks in your head better. The fourth day, if they're still here, then, we'll talk about any issues that they have. After they've read all our little booklets, I tell them to write down questions, and I'll be glad to answer any questions they have. I give them my phone number when they get ready to go home. I told them, I said, if it's anything inside, call your doctor. Anything outside, pouch-wise, call me, because that's my job. I would just like for everybody to know that this is not the end of the world. If they can remove cancer and you have to wear a pouch and you're alive and have quality of life, that's all that matters. The pouch is hidden under your clothes. Nobody has to know you have it unless you tell them. Most people that have gone through having an ostomy say, this isn't as bad as I thought.